You are listening to The Dish on Health IT, brought to you by Point of Care Partners, a leading health IT consultancy. Each episode will feature a rotating panel of senior consultants and guests who will talk about trends and innovations in health IT, while also highlighting how organizations can leverage these advances to solve their business problems. In this episode of The Dish on Health IT, we've got a very special guest, strategic advisor to CMS and administrator of the U.S. DOGE service, Amy Gleason. Host Tony Schueth, CEO of Point of Care Partners, and co-host Alix Goss, senior consultant and program manager of the HL7 Fire Da Vinci project, talk with Amy Gleason about the CMS Health Ecosystem Pledges and additional initiatives like the Rural Health Funding, CMS Access, and more generally, the role of artificial intelligence. If you have suggestions for future episodes, send us your ideas by visiting the podcast page at POCP.com under the Insights section to share your thoughts by submitting a form.
Welcome to The Dish on Health IT. I'm Tony Schueth, Chief Executive Officer of Point of Care Partners. Today's conversation is about something we don't talk about nearly enough in health IT, how real change actually happens when regulators, technology, trust, and lived experience converge. My guest today is Amy Gleason, Strategic Advisor to CMS and Administrator of the U.S. DOGE service. Many listeners know Amy as one of the driving forces behind the Trump administration's pledge-based approach to modernizing healthcare workflows by leveraging the health tech ecosystem. Joining me today is my co-host, Alix Goss, Senior Consultant at Point of Care Partners and Program Manager for the HL7 Da Vinci project, who brings a ground-level view from standards and implementation communities, hearing this feedback in real time. Let's start with brief introductions. Alix, would you go first, please?
Sure, Tony. Thank you very much. I'm really excited to be here today and to lean into my longstanding belief that industry should be driving standards that underpin our healthcare technology capabilities in support of patients in their care journey to achieve a better quality of life. For those of you who may not know me, as Tony said, I'm a senior consultant with POCP. For more than 35 years, I've brought my enthusiasm, passion, and integrity to strengthening organizations, public policy, and national standards to achieve healthier and more productive people. This includes work developing healthcare standards in the policy realm, as well as the EDI and fire communities. Doing boots on the ground work, implementing and complying with federal and state regulations, and aligning business strategies, systems integration, and operations management in both public and private sectors of healthcare. I also currently serve as the chair of HL7's International's Policy Advisory Committee, and I'm also HL7's liaison to and chair of the Designated Standards Maintenance Organizations established under HIPAA to maintain and update the technical standards for electronic health transactions for HIPAA adopted by HHS. This is in addition to my role in the HL7 Da Vinci project as the program manager.
And yes, you are. Let's now, Amy, we'd like to, would you like to go next, please? Please introduce yourself.
Sure. I'm Amy Gleason. I'm the administrator of the U.S. DOGE service, which is an organization at the White House that works across all the different federal agencies to modernize the technology, to improve data sharing, and to find efficiency, as well as we do a lot of work on fraud, waste, and abuse through data research. I lead a lot of the technology at CMS, and so I've been working closely with Dr. Oz on modernizing technology for both Medicare, Medicaid, and out into the healthcare ecosystem with all the healthcare providers and innovative solutions out there.
Amy, you have a really compelling story about sort of how you got into health IT. I'd love to hear that again. I enjoyed hearing it when I've been at some conferences. Could you tell us about that?
Yeah, so I started my career in nursing in the emergency room, and that's really the first time that I realized how dangerous it is when providers don't have the information that they need. And then we are really unrealistic in asking patients to remember all of their past history and medications, especially while they're scared or in pain. So that is actually what led me into technology, because I really saw that there was promise for technology to give providers better tools to really understand what's happening and to surface data that can help them give better care. And so I worked a lot in electronic medical records, trying to do this from the provider side. And ironically, I was working on health information exchanges when my then 10-year-old daughter was a competitive gymnast and cheerleader. And she was really active. We called her the Energizer Bunny because she just never stopped moving, flipping and twisting all over the place. And she started having all these kind of strange symptoms that didn't seem related at first. She had rashes on her elbows and her knees, but she was a gymnast. She was hitting the mats a lot, and we didn't think that much about it. She kept getting steroid creams and different things like that. And then she started having stomach aches and headaches, and she was missing a lot of school. Then it got to be really weird when I'd start to pick her up from gymnastics, and they would say she was sleeping because she was too tired to practice. And she started losing a lot of her tumbling skills. And then she started breaking several bones, some of them in gymnastics, which made more sense, but sometimes just doing simple things like walking down the street. She broke a bone in her foot, and she hit her elbow and broke her elbow just on the table. And the doctors, I kept saying, is something wrong with her bones? And they kept saying, no, her bones look healthy. And nobody could really put all this together. And then she was kind of accidentally diagnosed. They did a skin biopsy at the dermatologist on these rashes that were persisting and had now moved to every joint. She had them on her ankles, her knees, her knuckles, her elbows. And so they did a biopsy, and they found out that she has a rare life-threatening disease called juvenile dermatomyositis, which is a systemic vascular disease. So that was the explanation for all of these different things that had been going on. But it took us a year and 3 months to get a diagnosis. She saw many, many different doctors over that time. But every single one of those doctors could only see one part of her problem in their different chart. The dermatologist was looking at her skin, and the orthopedic was looking at her bones, and, the pediatrician was trying to figure out why she was getting so many headaches and stomach aches. So I think just nobody could see everything together. And I truly believe if one doctor had been able to see all of that, someone would have said, why is an 11-year-old that was previously healthy going to the doctor so much, and tried to figure all of this out? And I believe with the advent of today's AI that surely something would have been surfaced earlier. And the sad thing is that her disease gets worse the longer it goes undiagnosed. So we'll never know how much of an impact that has, but it's been 15 years and she still takes 21 pills a day and gets 2 infusions every month as treatment. She's 27 and she's doing pretty well, but it's a lot of burden on her just to try to live a normal life.
What a compelling story, and what a reason to get into health IT. Thanks for sharing that. This personal experience clearly drives your philosophy. You said, we can't regulate our way to success. And you often point to how quickly we've moved during COVID, when the industry was motivated by a shared goal. Now that you're sitting in the seat of government efficiency, how do you convince the skeptics that voluntary pledges can actually move faster than federal rules in peacetime?
Yeah, so I certainly do get passion from this, and Morgan gives me new examples of why we need to do this almost daily, just the struggles that she has as a patient. And so when I came back into government this time, I was a little frustrated because I had been in the administration 2018 to 2021, and I had worked on interoperability when I first got there, and even helped write a rule with Alex Muggy on provider access APIs, because I had launched the Data at the Point of Care project, which was giving providers claims data for their patients through APIs. And we wrote that rule in 2020. And I came back in 2025, and the effective date for that rule is January 1, 2027. So 7 years to get this thing that I'd worked on into practice. And you can imagine, first, that was just frustrating, but 2, technology has changed a ton since 2020. So I'm pretty sure if we were to write that today, we would write it very differently than we did back in 2020, yet we're still waiting to even get it into the market to see how it works. And so as I came in and really started working with Dr. Oz, who is also a very big champion of empowering patients and giving patients the tools to have a better, healthier life, we started thinking of how can we do this differently, and why isn't it working? We've been regulating this for 20 years, and in paper, it should work. Like, we've done meaningful use, and we have the Cures Act, and we've done TEFCA, and we've done CMS interoperability rules. So when you look at all of that, it should work. And in some cases it does. Like, we've certainly made a lot of progress, But in a lot of cases, we just digitized bad processes. So for example, my daughter has 47 different patient portals. That's just virtually impossible for any human to manage, much less to get a full picture of your information. And so we decided to do it differently. This administration likes to use the power of convening more than regulation. And so I was one of the first to go with this health tech ecosystem in my convening work. And so we basically said, let's just paint a vision of what we want to happen about patients getting their records, trying to unblock some of the things for providers, and a little bit of operational and payment use cases that haven't made much traction, and ask people to pledge to do this in 6 months and 12 months instead of years, and see how we can make change happen faster. And so we had about 60 companies that pledged with us back in July when we announced this at the White House with the president, the secretary, Dr. Oz, and I. And now we have over 600 people that are working on this. Our three main use cases are really patient focused, but in order to drive those, we have to fix the data interoperability. It's our theory that one of the main reasons that innovation hasn't taken hold in healthcare as it has in other industries is that the data is so hard to get. And so the first part of our pledge was really about interoperability, and we had several networks pledge to meet that, including all of the QHINs. And then we had 3 patient use cases that were kill the clipboard. So a patient could use their identity instead of all these portal logins, such as Clear or ID.me, to get their records and then put them in any app they choose, and then use a QR code to scan at the provider's office to share their record with the provider, just like you do at a concert or at the airport. And then once you have that data in an app that you choose, then you can use conversational AI on top of that to be able to get personalized recommendations and guidance in between visits and in your daily life. And then diabetes and obesity, straight up Maha lane of helping people get personalized recommendations on diabetes and obesity treatment and prevention. And so that's what we launched. We have over 600 companies now working in our Slack channels and our working groups. And our first deadline is March the 31st. And we're really excited to see progress.
Where are we? What is the progress? Are we starting to see real examples of killing the clipboard for patients yet? Or is this still largely in the planning phase?
So, as you might happen, we've had a lot of debates over the last few months. So part of this idea is really for CMS to not be heavy-handed, but to let industry say, this is what will work best for us. We tried to get all the stakeholders into these work groups. So we have patients and caregivers, providers, payers, patient apps, EMR vendors, data networks, kind of everybody working together. And we've had a lot of debate. And so we eventually have gotten to what we are defining the minimum viable product, or MVP, that we will agree on for scope in March. And we started testing. So we had a connect-a-thon in November where several examples were shown where a patient app used IAL2, got data, put it into their app, and then used a QR code. The EHR came in and read that QR code and put it into their chart. We had several using that patient data to personalize recommendations for conversational AI and for diabetes and obesity. And they got up and demoed live code in front of everyone, which is always scary. But it was great progress. And I think we're going to see a lot of the pledges make it by March 31st. Will it be the final perfect product? No, but it'll be a great first minimum viable product that we can get out there, test it, see it work in real life. And then in July, we'll have a second phase where we'll improve on it and we'll continue to improve going forward.
That's exciting, really exciting. So this is your second stint in the Trump administration. What surprised you most, kind of this time around?
So I think probably the things hadn't changed a lot in 5 years since I was gone. That was probably the biggest thing. But as you said earlier, I do talk about how COVID changed a lot of the way government works. And my first time there, the first year was kind of what you would expect, pretty typical government work and a lot of bureaucracy. Things took a really long time to happen. And then it was instantaneous during COVID that things that used to take a year or two would be done in a day. And it was just insane how it could happen. It was like, wow, we could have done this all along. And so I feel like this administration learned from the last time and really came in. And it's like COVID without COVID. We're able to move and do things much faster and to really get rid of a lot of the bureaucracy that doesn't help things and try to deregulate and get some things moving in a faster way. So I guess just being able to actually move at this speed is really exciting.
It is exciting. So, Alix, I'd like to hear what you're hearing about how members of the Da Vinci community and the industry at large are feeling about the CMS pledges. Does this feel meaningfully different from past initiatives, or does it still feel really early to you?
Well, Da Vinci's membership is full of innovators seeking to improve value-based care exchanges, and there's a lot of overlap between the pledgers and the Da Vinci rosters. And this makes sense to me because the thought leaders of Da Vinci recognize and have pushed for industry to drive the development of standards to underpin their business models that are reliant on data and over investing in proprietary approaches. They understand the value of collaboration and joint problem solving while remaining competitive. And this is sort of analogous to what's happening within this CMS pledge group. They're also applying a lot of the lessons learned from the trajectory from HIPAA to high tech to the Cures Act. And I think that even the COVID analogy that Amy brought in is helping us all to really understand that we have to work together to leverage modern API capabilities, and that we do need the standards to underpin that high fidelity data and the level of trust that is needed between payers, providers, and patients and to achieve those patient outcomes. I do think it's still a little too early to say what measurable, ubiquitous progress we'll achieve from the pledging entities. As all too often, industry has been really, moves at the speed of the regulatory triggers and signals. But I'm really hopeful that maybe this experience now with the pledges is the accelerant to innovation that we really need. It's time for industry to step up. They've been talking about this for a lot of years, from, back in my days with NCVHS. Looking to really drive the predictability and standards alignment with business models. And so I'm hopeful, but I think there's a lot of influence by this administration. We'll see how long it sticks.
I'm hopeful as well and excited about the progress that we're making. But speaking of drivers, CMS recently announced a historic $50 billion investment to strengthen rural health, alongside the new access model, which pays for outcomes. Do you see a strategic link between this new capital and the ecosystem pledges? How can we ensure this funding helps rural providers who often struggle with legacy technology actually adopt these modern tools rather than patching old tool systems? Amy, what are your thoughts on that?
Yeah. So when we first launched this health tech ecosystem in July, we hinted that there would be incentives coming because we know that healthcare moves where incentives drive people. And so we're trying to really look at this both as carrots and sticks. So information blocking, which we are beginning to enforce, is the stick. We really want providers to be paying attention to that because we are going to be enforcing information blocking. But on the carrot side, we have two so far, as you mentioned, the Rural Health Transformation Fund, which is $50 billion going to the states directly. But some of the key criteria for those awards are around the health tech ecosystem. So we really encourage the states to put in their applications that they would be working with CMS aligned networks and with health tech ecosystem apps in their communities to really drive more patient tools and provider tools to be able to have better outcomes. So most of the applications that we saw come in had these key items in there. And as we approve those items, they have to come to us for approval before they can initiate their projects and get the funding. And so we will be monitoring that to make sure that it's going to rural providers and that it's being used there. And we have clawback ability if they are not using it on the rural providers. So I think that's one way that we'll make sure that it stays in rural and has that impact. I think for the access model, as you said, it's to pay for outcomes. So this is the first real example of technology-enabled care or apps being able to bill Medicare for outcomes. So in this case, an app or some kind of technology-enabled care can register as a Part B provider under Medicare with their medical director. They have to have a medical director to become a provider. And then as long as they are driving outcomes in one of the 4 tracks, which are early and chronic cardiometabolic disease, musculoskeletal disease, and then behavioral health for depression and anxiety. And so for those pieces, you have to manage all of the pieces of a track and drive outcomes. So things like lowering blood pressure and reducing A1C and improving kidney health, or reducing musculoskeletal pain or improving anxiety and depression. If you can prove the outcomes from that, then you get paid on the outcome. And part of that is that you also have to keep the provider in the loop. So the providers can also get paid a small amount to refer patients to this or to review the care plans as they go through. And so we really have tried to push this out so that it's a really good entryway into relieving some of the burden on providers and helping rural providers as well to be able to have some extra tools that can reach their patients without as much human overload of calling patients and trying to work through this, that we can use technology to help do some of that, and the personalized nature of this with patients, that it can talk to them every day. You know, the app doesn't get tired of explaining what you need to do about your diabetes as much as humans that can't have that same conversation over and over or reach as many people. And so we're really excited about those. We think they're going to help rural providers and urban providers do that. And these incentives are already driving people. We've had a lot of interest in the access model, and every state participated in the Rural Health Transformation Fund.
I love that, both carrots and sticks. I was involved in electronic prescribing, and when electronic prescribing started to take off, it was during MIPA, and same model or a similar model where there were carrots in the beginning and sticks at the end of that. Can you go a little bit more into into what some of the, how you're going to the penalties might be, the stick part of it? The holding people accountable for information blocking.
Yeah, so information blocking has up to a $2 million fine per occurrence. And so if providers are not sharing data, especially in our ecosystem, we're pushing so much on patient access. Patients have a right to get their information through HIPAA as a right of access, and through the Cures Act, they have the right to get that from any app that they choose, as long as they have the technology means to do, which every EMR should have that ability based on certification. And so that's really the main message, is that we are going to start information blocking. It's been out, but it wasn't really enforced in the last administration. But we have put money towards enforcement and are coming to providers who are not participating.
I love that, because like you said, in the past, some things haven't been enforced. Let's switch gears a little bit. Alix, from a standards and implementation perspective, where do rural providers tend to hit the biggest friction points?
This is a great question. In my prior role as Pennsylvania State Health IT Coordinator and Executive Director of Commonwealth's HIE ecosystem, I've seen firsthand the challenges of rural communities. And Pennsylvania ranks third in the nation for the total number of residents living in rural areas, following Texas and North Carolina. And the friction points come from a lot of resource limitations to achieve the care they seek to deliver to their neighbors. And these are financial limitations, they're human resource limitations, and the strain is real, and it constantly presents challenges with wanting to adopt new technologies and capabilities that are enabled by standards. That takes money, and they don't always have those financial resources. They also have challenges within their workforce, because their time is so limited by their staff to allocate time to new efforts, investing in their own skills and knowledge to assess the new technologies that are being rolled out and the compliance opportunities. And compliance elevates the bar to let everybody know these are the best practices. This is what you should be using to get to the best outcomes possible. And so this also correlates to technology tools and participation in policy and standards development to ensure that their workflow needs are fully met. They don't have time to think about coming into the standards landscape and making sure that their approaches are being thought about. But they also are struggling with keeping up with all the changes and bringing world-class care to the rural settings and those tools that can come with that, unless they're affiliated with a big institution. And that's just not always possible in a rural landscape.
Yeah, well said. I'm also from a rural area, and I agree with everything that you said from our market. Let's pivot a little bit and talk about AI for a second. We're seeing major AI players like OpenAI and Anthropic included in the pledges. The question of risk keeps coming up related to AI's use in healthcare, whether used by the patient or in the exam room. You've compared, Amy, AI adoption to evolution of autonomous vehicles, starting with no passengers and moving incrementally. How do we encourage providers to use these tools for things like RX refills without waiting for heavy-handed FDA regulation? Who owns the risk in this interim period?
Yes. So I have used the example of the cars. So I was recently in San Francisco for quite a few different things, and I rode in the Waymo cars, which took the approach of cars driving around first, mapping the roads without passengers. Then they started adding passengers, but they only go on certain routes that they've mapped out super well. Like you can't just take it anywhere. You have to stay in their area. Where the robotaxi is a different model where they can take you anywhere, but they have a human sitting in the driver's seat to make sure that they can intervene if there's anything needed. So it can tackle more complicated things, but can go anywhere. So I think this is going to be a similar path that we take in healthcare. I think the new Utah prescription refill pilot is similar to the Waymo example. So refills that are on people that have been on a med for a while are almost always refilled unless there's some issue that's come up. So it's a perfect example of how AI can query for some different things or look at your blood pressure results or different information and can decide whether it can refill the medication. And in that case, that vendor that's doing that pilot did get malpractice insurance. So they are going to be taking on some of that. They clearly are aware of those issues. And then on the other side, where we have the human in the loop, then we're having the human that's there to make sure that it's safeguarded and it can happen. Think I'm a cancer patient, I need to get treatment or I need different things. Then you may have an AI that could help study the data and give recommendations, but it should still be a human that's really deciding all of this and driving the change. And that way they're just guided by AI to get some different information and help. So I think we can really follow those two models, but I think we're going to have to work on the regulations here and figure out exactly how we go forward. I think HHS and this administration really believe in light regulation that is not state by state, where it's very hard for innovation to keep up. But we want to try to, have clear entryways to how you get guidance from the FDA, for example, and have clear regulation, what is and is not there. But I think that's about where we are right now. I will say that I think the biggest thing that's going to drive these things at this point is patience. I think I've heard the stat that over 200 million people are asking for health-related chats right now a week. And so I think patients are already there and they're going to be using it whether we want them to or not. So I think it's a good time to embrace that and figure out how we do it safely. I'll give one example of my daughter's care. She has been getting treatment, as I said, for 15 years. She tried to get into a CAR T therapy trial because she wanted to go off of her meds. It was like the first real hope we've had in 15 years. And she went there and they said, I'm sorry, you don't qualify for the trial because you have overlap of ulcerative colitis. And she was really frustrated. And she took all of her medical records and threw them into ChatGPT and said, find me a new clinical trial. I can't do this one because I have ulcerative colitis. And ChatGPT came back and said, actually, I think you're eligible for that trial because I don't think you have ulcerative colitis. And she's like, what? And it said, it read her biopsy from 15 years before. And she has microscopic lymphocytic colitis, not ulcerative colitis, which the treatment would have been the same for 15 years, but it does not exclude her from the trial because it's not as fast progressing and it's not as dangerous for her to go off of her meds to try the trial. And so it's amazing that that can happen. And that's just one of many examples that we've used this for and found. And so I think patients are going to do it anyway, but we would rather them do it with their medical records as the foundation, because patients won't ever be able to communicate all their results and all their history and all that information to prompt AI appropriately. But with the medical records, it can personalize it. And as someone told me recently, the models today are the worst that they'll ever be. They get smarter every day. And so I think this will continue to grow and change.
I love that story about your daughter and the clinical trial. Thanks for repeating that. Alix, what are you seeing and hearing out there? Are standards and data quality keeping pace with AI ambition?
I do think standards communities are keeping pace with while looking to the horizon to continue to meet the rapid evolving data and societal needs. Although I have heard some troubling remarks about the needs for standards and implementation guides as to whether we need them at all. But in recent months, it's been good to see more wide-scale understanding emerge on the criticality of standards and the related specifications and terminologies. They enable interoperability and improve data quality, protect privacy, foster trust, allowing AI to safely deploy agents to manage a wide range of tasks. At the core of AI models is the need for consistent, high-quality data to facilitate better data normalization, to fuel the training and operation of AI models. There's also an interplay of data capture throughout the healthcare system and diverse actors. We have a ton of legacy data already being harnessed for AI models, kind of to Amy's point about it, they're the worst they're ever going to be, they're only going to get better. And those in health IT know that data is really dirty. As we introduce more AI tools, we'll improve the capture and storage and normalization of the data, and our AI-based capabilities will continue to improve. I'm also hearing concerns with trust and transparency from the consumer citizen perspective, and knowing that we have the guardrails and mechanisms to address the unintended consequences and learnings from AI usage. I have lots of optimism about the augmentation to keep humans involved in the right places and to harness the power of AI compute and the resulting insights. And I think standards communities can help us foster the convening and dialogues that we need to continue to meet the needs of society and our data underpinnings.
Standards are still going to be necessary moving forward, aren't they?
You know, some of us might actually say standards are sexy.
I think that's a good way of saying it. Hey, let's change gears a little bit. There's some specific friction points that haven't been taken on directly. For example, we've heard some buzz about pharmacy prior auth and diagnostic imaging, and those might be included in future plans at the federal level. Based on the pledge work so far, is there an indication that there's an appetite to tackle pharmacy PA or diagnostic imaging next, Amy?
Yeah, so it's been interesting as we've evolved through this process and more people have pledged. As I said, there's 600 companies now that have pledged, and they're all in these Slack channels and work groups. And so from that, people started saying, hey, this is working and we're making progress. Could we have other pledges? And so we were pretty excited to see that happening. And so far, some of the suggestions that we've heard pretty unanimously from the group, not promising that we'll take these on, but things that the community really wants are prior authorization testing ahead of mandates that are coming out. Diagnostic imaging, which we left out of the original vision because it seemed to be the line where people could do something quickly by March and July and not. And so we didn't include them in the first pledge, but we know, and I've had tons of examples of this with my daughter as well, of how important those are. I think some of the other ones that we've heard are real-time benefits checks, scheduling interfaces, and some bulk fire performance testing and issues around the bulk fire needs. So those are the ones that we hear the most. And I think we're pretty interested in taking on some of these use cases as our next batch of testing to do.
That's really exciting. And it also speaks to sort of the value of the pledges. I mean, if we weren't going places, if we weren't making progress, people wouldn't suggest other areas. So that's really exciting to hear.
I think it's the first time in a while that it's not like kind of locked away in a room of what's happening with people, or that people have to join, a certain small group of things. So I think it's got every stakeholder in every conversation, and they can drag as many people in as they want, which is really helping.
That is absolutely. So this is a perfect transition to standards. There's active work within the DSMO, the Designated Standards Maintenance Organization, to incorporate fire into HIPAA, Alix. I'm going to ask you to respond first, since you're the DSMO chair and have held various roles within HIPAA standards, including your 2-term role on NCVHS.
Thanks, Tony. I think that it's very interesting to see what's happening in the realm of prior authorization. As Amy noted, that there has been, a desire to do testing around the prior authorization fire end to end. And Da Vinci did do this as a part of our HIPAA exception that we put into the National Standards Group. and completed that and pilot demonstration and produced our report. We've had that recent listening session by the National Standards Group, which really is emblematic of the enforcement discretion that they put out akin to the 0057 or interoperability and prior auth rule release. And the logical next step has been for the National Standards Group to solicit feedback from the designated standards maintenance organizations, who a lot of folks may not even be aware of their role in consulting with the federal government related to the HIPAA advancement. And so the Da Vinci community remains very engaged in testing and piloting work, and has brought forward our experiences into that listening session along with HL7's testimony at that point. So we're really hopeful to see some further opportunities for all of industry to weigh in on potential for a FHIR end-to-end solution for prior authorization, replacing the 278X12 transaction, which has had really limited uptake during the quarter century that it's been in place or more. So, I think that there's a lot of opportunity ahead, and I think that some hopeful policy opportunity to comment is on our doorstep, and we can all engage in responding to that, and then also not only modernizing our transaction flows to API capabilities, but to also up the ante for industry to help weigh in on the migration path that we'll need to take to support an and type of community with X12 legacy environments along with the modern technologies.
Amy, do you have anything you'd like to add relative to how we're modernizing or updating the HIPAA required standards factors, or in support of other work taken on by HHS agencies across the board?
I think I would just like to also agree with Alix and say, please comment on these. We'd really like everyone to be involved and share your experiences. I think we're really excited about testing some of this and hoping we can get a pledge group going for that, like I'd said, because I think it'll be a good chance to further that work. And I love the move from X12 to FHIR.
Well, I'd like to chime in there and also point out that Da Vinci has a prior authorization implementers community, which is helping to bring forward learnings and understandings. And ultimately, I'd love to get to metrics from that group. Might take us a little while to get there. Everyone's a little focused on making 0057 a real thing in the marketplace. But not only do we have the prior authorization implementers community, we also have the Trebuchet community, which is a project within Da Vinci that brings together trading partners to do like pre-production deployment testing and collaborations. We are also doing this with our patient cost transparency work, where we're actually piloting the good faith estimates and advanced explanation of benefits, implementation guides. And so part of Da Vinci's commitment is to go beyond the connect-a-thon model of testing implementation guides during the development process and really looking to advance the piloting work that gets those real scalable lessons learned. So maybe, Amy, we should talk about how to bring these communities together, because one of the things that I think everyone's looking for is a new benchmark of success is that we've done industry-wide testing and can prove out scalability, yet we've adopted HIPAA and meaningful use without any testing.
Yes, I 100% agree, and we should definitely join forces.
And I also want to sort of emphasize one of the things that you said, Amy, which is the importance of commenting. I did a Monday Musing, a column in LinkedIn, and we made the point that it's really like voting. It's really kind of, part of our civic duty, if you will, or our duty as folks, as experts in health IT to comment. And you guys do read every one of our comments and consider every one of them. And so I just want to reinforce that. The other thing I want to do is I'm going to jump slightly to that electronic prior authorization in the pharmacy realm and just distinguish that from that in the medical that Alix works on. And in the pharmacy realm, I've been involved in that for a couple of decades. And we did go down a different path of leveraging the NCPDP script standard for that. And the reason was because the vision was that when a doctor goes to write a prescription, they see that prior authorization is required. Behind the scenes, the EHR requests prior authorization from the payer. They get a response back, and then the doctor can have a conversation with the patient. Do you want to proceed with this? And the prescription can go electronically and automatically into the pharmacy. There's still FHIR involved because FHIR needs to be leveraged to sort of extract information out of the electronic health record and include in that prior auth request. So it's a different model, and we're looking forward to CMS sort of putting out a notice of proposed rulemaking or comment, asking for comments on that as well. Let's switch gears a little bit to the future of FHIR and removing regulatory hurdles. There's a strong current in the industry right now aligned with the broader efficiency mandate to reduce certification burdens and cut red tape around health IT. However, some might interpret this deregulation as a signal that we can skip the hard work of standardization and just leapfrog straight to AI automating everything. Regardless of how specific regulations shake out, why is FHIR still the necessary fuel for these large language models? Can we actually have efficient AI without that structured data foundation? Amy, I'd like you to take the first shot at responding to that.
Yes. So first, I'd love to congratulate my colleagues at ASTP ONC for their deregulatory work, because I don't think that that's signifying anything is not important. I think it's just removing the burden from the things that we don't necessarily need to regulate anymore and moving to the things that we should be moving towards. So I think it's a good pattern to deregulate as we move forward. Otherwise, you just end up with a lot of extra burden for not a lot of value. As far as having standardized data for the models, so this was one of the questions I actually had when I came into the administration. Is I will admit I was a little bit in the, are we even going to need FHIR anymore before long? And we could just maybe hop on to AI and not deal with this anymore. But sadly, I have been educated pretty well from a lot of different labs and different people that while AI can certainly do a lot with free text, it is so much better when it has standardized data, because it can make the data much more meaningful. It makes less mistakes, and it can feed in and grow those models in a different way. And so sadly for me, I learned that we really do need FHIR, and it is very helpful, and we should continue going on it.
Absolutely, we need FHIR. No question about it. Alix, what are your thoughts on this?
I think if you want high fidelity, discrete data, you're going to need to have people or ambient listening tools capturing the data and parsing it out to feed those models. Just as Amy has said, it gives us the building blocks that we need for a long time to come. I'm sure there's going to be something in the future that's going to be even, dare I say again, sexier than FHIR, but for right now, FHIR is where it's at. It's got that potential to meet the legacy standards needs and map that to FHIR and support those AI models, really being able to be much wiser in the end because they've got a better data quality through FHIR.
So you're saying within sexy standards, FHIR is sexy. Is that what I'm hearing you say?
Yeah, let's go with that, Tony.
All right. Underpinning all of this, whether it's AI or FHIR, is trust. We have the best APIs in the world, but if the actors don't trust the network and understand how the data can be used, data doesn't move. How is the ecosystem initiative tackling the trust framework issue different from previous attempts? Amy, can you take a shot at that?
Sure. I will say that this was one of the key themes we heard when I was trying to figure out why things weren't working from regulation, is trust. So everyone is very concerned about this topic, as they should be. So there are a few things that we are trying to tackle. And also, I also want to just say that we're not trying to change TEFCA necessarily. Our partners at ASTP ONC are running great programs and trying to drive TEFCA forward. I think we see TEFCA as really like the regulatory floor. So everyone should do the things that are in the regulation. And then we're trying to use this pledge and ecosystem work to be an accelerator to kind of move and test things and get people to do them voluntarily. Of course, if we don't move to everyone doing them voluntarily, eventually they will make their way into the regulatory floor. So they work hand in hand together. So it's not an either or, really. We work together. So as far as trust, we really felt that there were two parts of this that we could provide to help with trust. So one is just adding the individual access verification, or the IAL2, through things like Clear, ID.me, and login.gov. We are adding that to both the Medicare.gov site, where we're redoing that site to be both for patients and their caregivers, as well as adding the app library, where they can get trusted apps there that have been certified on either Caring Alliance or the DIME. So those have both agreed to put very patient-friendly language, put their terms of use up front, and to treat data basically like it's HIPAA data, even though it's not necessarily in a patient-facing consumer application. So then we believe the ecosystem can rely on those digital credentials to build out different apps and to have that same trust. From the provider side, we're building a national provider directory. So there are over 5,000 different provider directories at a cost that's estimated of $6 billion in the healthcare system every year. And that's because there is no single source of truth for providers out there. So everyone takes CMS's data, and then they go and try to make it updated every day and continue that process, every single health system, every single vendor, every single payer out there. And so we're creating one national provider directory at CMS, where we're taking our CMS data and we're making the most current version of that available. And then we're allowing the private sector to come and update that information so that everyone can just put it in one place and then reuse it over and over. And so we think that that will also be helpful to have a trust factor, mainly because we're adding identity to that also. So providers will come in and validate with their identity, and then we will know that they're a valid Medicare provider. So initially, when someone requests data through a network, they can ping the API at the provider directory and say, is this a provider in good standing, and have they verified their identity? And then that can help with the trust factor. So in our interoperability framework, we said that if a provider is verified through the provider directory and has validated their identity, and they request data and say it's for treatment purpose, then you must treat that as treatment purpose. And then if they're doing something wrong, then you should report that, most likely to OCR, but if to someone else, it might be a different use case. But that way we can have that trust coming through and not be redefining HIPAA and redefining trust and what a provider is over and over. So we think those are going to have a big impact, both for patients and clarity and expectations, and providers. And I think the other side for patients is we're also mandating transparency to the patient around who's requesting their data and why, just like you see in your credit report. Patients will be able to see that. And then also for providers, you'll be able to see how many patient transactions they're getting and how many they're responding to, how many treatment and how many payment and operations queries they're getting, and how many they're responding to. And also the apps that are validated and out there, so you can see their volume as well. So we think transparency is sunlight and helps a lot with this.
Absolutely. And trust is critical. So as we come to the close of this episode, I wanted to ask a final question that we ask on every episode. If there's one thing you'd like our listeners to do differently or think differently about after this episode, what would it be? So Amy, I'd like to start with you with that question. What would you like them to think differently about?
Yeah, so my main ask is, I've heard for years that providers feel like they're kind of the back end of everything and get handed down things that they have to do, either through regulation or through committees that decided things. And I want to encourage them to come and join in this work. If it's not them directly, someone on their team, even if it's their compliance people that are telling them they can't do things, we're really saying this is your chance to have an equal voice to everyone else. I think providers tend to kind of give up their right to have a say to either their EMR vendor or to someone else. And we want them to come be part of the situation so they can say, this is what would make a difference in my life. I wouldn't use that. That doesn't work for me. And this is kind of a come one, come all, come big, come small. Like, we want everyone to play in this. And so I'm really encouraging providers to come and join us in this effort and come be part of the discussions.
Alix, do you have any final thoughts?
I love what Amy said. And I think that standards are essential and people have to show up and participate. This means they need to put line items in their budgets and get designated resources to track with it, to weigh in, to comment, to be a part of the process, because it takes a village.
It absolutely does. Amy, thank you for joining us for this groundbreaking conversation in both lived experience and practical reality. And thank you, Alix, for bringing perspectives of the broader standards and implementation community. For our listeners, this work sits at the intersection of policy, technology, and trust. Movements don't replace mandates, but they can show us what's possible before rules ever hit the Federal Register. If you're interested in listening to past episodes, you can find this and past episodes of the Dish on Health IT wherever you get your podcasts, as well as on Healthcare Now Radio. So until next time, Health IT is a dish best served hot.
Is it a challenge to stay on top of interoperability regulations and the flurry of activity with fire accelerators? Email us at interopoutlook@pocp.com to learn more about our Interoperability Outlook subscription monitoring service.